Why do you want hair?
I think I'll feel better about myself.
There are certain advantages to being bald, Richard.
Well, that may be so, Doctor, but I want hair. I want lots of hair.
Right off the bat, I want to ask you a question that has been asked a lot. And it's not only specific to you, but specific to FUE as a whole. There seems to be this notion that, hair transplant surgeons extract out of the safe zone. So out of the zone that will be susceptible to DHT. And this has come up with you. I know that you saw the thread and somebody said, well, how does Dr. Zarev know that he's not extracting outside of the safe zone?
The safe zone for every patient is different. And during the consultation, I make a very precise quantitative assessment of the donor areas. And I can judge accurate or precise where is the border between the safe and unsafe donor areas. And I stay only in the safe donor area. We discussed the safe donor area, yes? And your question is, am I extract outside of the safe donor area?
Yes.
And my answer is no. Okay, now see.
Perfect. I see right there.
This donor area have, of course, the follicle units in this donor area, depending on the place, have a different characteristics. Here in the high and middle part of the occipital area, the hair follicles are with more cycle of hair growth. The hair is thicker, and of course, this hair is stronger compared to this hair in the left part. Now, from this donor area, I extract from everywhere, but this is the border of the donor area. In this area, between this line and this line, I implant grafts there, not extract, of course. And the goal of this is to have a very soft transitional area between the donor and the recipient area, because this patient is normal 7. But in this case, it's easy to predict where is the border of the donor and the recipient area. When the process of the baldness in younger patients is still in progress, in these cases, it's more different to understand when exactly is the border to the safe donor area. And that's why you need a very precise quantitative assessment of this donor area. You need to speak with the patient family history, and this way you can understand which neuro this patient can reach. And I never start surgery before I understand what will be the volume of baldness in the future for this patient. And I always calculate the number of grafts that is needed to correct the current condition of the patient, and what will be the number of grafts that the patient will need when he reach final stage of baldness. Neuro 6, Neuro 7 depends on his genetic characteristics, of course.
Do you require your patients to be on medication before you do a hair transplant? What's your protocol?
Usually my patient after the surgery use topical minoxidil 5% for the men, of course, and 0.1% finasteride, again topical. Some of my patients use oral finasteride or oral dutasteride, but depends on them.
What if a patient says, I don't want to use anything?
I spend 2 hours for consultation usually. And during this consultation, I assess very precise the condition of the patient and the future losses. And I know what will be the number of grafts that this patient will need when reach final stage of baldness. And if the patient have enough follicle units to correct even this baldness when he reach final stage, then we can go even without medication if he don't want. If the number of grafts that his donor areas have are not enough, I explain the patient what will happen in the future if we start now surgery and he don't use any medication and he reach final stage of baldness. And of course, if he decide not to use, I plan the surgery in the way that in the future he will achieve acceptable result, like a patient or like a person who start to lose his hair, for example, in the crown or in the mid scalp, like a normal baldness.
Okay, so next question is, you have a very specific technique and a very specific tool, right? Yeah. We don't know too much. Nobody knows too much about this tool. But the questions that a lot of people have been asking me is, will you at some point manufacture this tool, and will it be available to other surgeons to use? Because it seems that this tool that you've developed has helped you immensely in how you perform these hair transplants and how you're able to achieve, such excellent growth.
Listen, I developed this equipment in the last 11 years. And the main difference that allows me to extract such big amount of grafts without causing anesthetic dilution is because of the very high contraction rate in the first few hours after the extraction. very high contraction rate of the surgical wounds in the first few hours after the extraction. This is the main difference. Of course, for this purpose, I use a very small size of punch, and this equipment allows me to do it. And usually, I can extract up to 60% from the amount of the follicle units in the donor areas without causing anesthetic dilution. And yes, in the future, I plan to teach some other surgeons to start to perform this type of technique, to use this type of technique, but I'm not ready for this, still not ready. Maybe I hope in the next 1 or 2 years to finish my developing, and then I'll try to start to teach some other surgeon to perform the same extraction like me and the same approach.
Amazing. I think a lot of people are excited for that. Another question that I think everybody wanted to know is, does Dr. Zarev use microscopes? There's been a lot of controversy that you don't use microscopes. And if you don't use microscopes, explain why you don't use microscopes, or why it hasn't affected your practice.
Now, at this stage, I don't use microscope or lens because I don't need. The type of the extraction that I use, the equipment, allows me to extract single hair follicles if I need. Usually for this purpose, I use the punch size between 0.45, 0.5 millimeters. And this way, I extract single hair follicles from the area that I want without risk of transaction. And something else, when I make the FU extraction, usually my grafts are very clean. They don't have additional tissue, and I don't need to trim them to make it smaller for the better implantation. Just they are without surrounding tissue. And these don't require to use microscope to checking or to trim them.
How do you ensure that the hairline has single-haired follicular units without using a microscope?
I'm sure, because I told you, I can extract single hair follicles from the area that I want with this equipment without risk to have some additional hair close to this single hair because the size is very small.
People ask, does Dr. Zarev use beard hair or chest hair? It seems that you're able to achieve these incredible numbers, 12,000 grafts, 11,000 grafts, using just scalp hair.
Yeah, I understand the questions. Yes, I achieved this 11, 12,000, even more, but most of the cases are scalp grafts because, one more time, I can extract up to 60% from the amount of the follicle units. And I will show you some, again, interesting case I showed you before a few minutes, but we'll back to this case, in which the donor areas is in very bad condition, but again, allows extraction of 12,000 grafts. And in this case, many of the surgeons, if they decide to make a surgery, they will decide to use beard hair or chest hair. But for me, the most natural result can be achieved with only scalp hair. Of course, there is exceptions. When the patient don't have enough donor areas, don't have enough follicle units in the donor areas, and still want a surgery or have a previous surgery with bad result and have compromised donor areas, then I use beard in very rare cases. But to use beard and to achieve a good result, you need to have a close characteristic between the hair, the scalp hair, and the beard hair. Otherwise, the result can be very, very unnatural. And the main goal of the surgery is to look natural. Sometimes it's better to look like person who start to lose his hair, like, for example, in the crown or in the mid-scalp. Compared to this, you have some different type of hair which grow different, change the color in different time, and looks very unnatural when the characteristic of the, for example, beard and scalp are very different. In most patients are different. But again, I use beard in very rare cases when I see enough close characteristics between the structure of the hair, of the scalp hair and the beard hair. And see, this is the patient with 12,000 grafts. It's one of the last patients that I upload in internet, in my website. And this interesting case because of the very bad characteristic of the donor areas. And at the same time, I just use only scalp hair. See, this is the result. 8 months after the second surgery, and I made 2 surgeries here, and each of them was in 2 consecutive days. See the hairline. And of course, this patient have a very high hairline, but it's normal because his age is around 50, and it's acceptable to have this high hairline.
Yeah, he's 50, so it looks reasonable.
Yeah, we need to take into account, of course, this high neuro because he is neuro 7 and with diffuse thinning in the temporal areas. I will show you. See,
Incredible. Wow.
we've come and see the donor areas now. This is the donor area before and immediately before, and this is 8 months after the second surgery. And now I will show you the detailed information about the first and the second surgery and the recovery process in this patient.
How many grafts did he have in the crown? Because that crown looks incredible. It's insane.
I achieved equivalent of the 55% from his average initial density of the occipital area in the crown. In the frontal area, equivalent of almost 60%. But something more interesting, I extract from these donor areas, see, 67% in this case, a little bit more compared to the my general standard. 67%, but his contraction rate of the surgical wounds was very high, and this allows the donor area to look like that even after 67%. And I extract from the temporal areas around 60%. And again, still look acceptable.
Yeah, it looks.
Yeah, and this is the crown. And now this is the micro camera picture. This is after the first surgery. Again, hairline 10 days, and this is the 1 to 9 months after every month, and this is before the second surgery. Again, immediately after the second surgery, 10 days after the second surgery, 3 months here, 5 months, 7. And this is 8 months after the second surgery, the final result. And I will show you now. See, this is the frontal parietal area. Again, the same pictures.
So in that, have you noticed that the crown takes a little bit longer to grow?
In some cases, yes. Maybe the difference is 1 to 2 months more than the frontal area because of the blood supply. It's reasonable.
Yeah.
The blood supply in the crown is worse usually compared to the frontal area. And see, this is the donor area, and before here, donor area, occipital. This is short hair before, and here is this is 12 hours after the first surgery, which was in 50 days. See the
12 hours.
The surgical hole.
You can barely see the holes. They look almost like
because of the very high contraction rate, and because of this very high contraction rate, the distance between the hair become less, and this can compensate some of the extracted amount. And usually I extracted around 60% from the amount, but I reduce the density, for example, with 40 or 45%. Because of the very, very low transaction rate, almost zero, I can use all the grafts. And this makes the difference with the numbers.
Those are the punches. Wow.
This is the micro camera pictures, 12 hours. And if you see the skin, see the direction of the skin, how become deep because of the contraction.
And that's from the tool you use.
This is, the equipment makes the difference in this case.
Yeah. Wow. That's
and
incredible.
This is 1 month, I think, 3 months, 5. This is before the second surgery. See, this is the result of
the borders. The borders that you transplanted afterwards.
Yeah.
Okay. See,
I can share with you, if you're members, 2 of my presentation in which I speak about my approach to the donor area and my approach to the recipient area. And when they watch this presentation, they will understand more about my approach to the donor and the recipient area, and I can answer more precise of his questions.
So what is your approach to surgery? If I'm a Norwood 6, and I say I want to have a hair transplant with you, Dr. Zarev, I have, very diffuse Norwood 6 pattern. My family history is, my grandpa is a Norwood 6, and
but you mean that this patient is it's complete Norwood 6 or will become Norwood 6 in the future?
pretty much like 80% Norwood 6. Maybe they have a little bit of hair, but
For
they're pretty much
example, I will show one case which will reach Norwood 6. It is
yes.
almost Norwood 6, but still have some hair.
Exactly.
Yeah.
That's exactly what I'm talking about. Yeah, like that.
Most of the patients first contact me like via email or call or phone call, and they want to send me pictures to assess his condition. And I said that this is impossible, of course. I see the pictures, but I require, especially in case like this, personal consultation first. Come to me, and I make a very precise quantitative assessment of the donor and the recipient areas. This includes microcamera pictures. I measure the size of the areas, and then I calculate what is the number of grafts that I can use from these donor areas without causing anesthetic dilution. Then I calculate what is the number of grafts that this patient needs to correct his current condition now, and what is the number of grafts that he will need in the future when he loses all sensitive to DHT hair follicles in the recipient areas. If I decide that he have enough follicle units, then we make a surgical plan. For example, in this case, done 2 surgeries. The first surgery was in 2 consecutive days and was around 8,000 grafts, 8,200. And then the second surgery was 9 months later, and I implant 4,000 grafts, a little bit more. This means that this patient has 12,000 grafts. But I can extract from these donor areas, after the assessment, I saw that I can extract around 14,500 grafts. And in the future, when this patient loses all DHT sensitive hair follicles, he will need additional transplantation of approximately 2,500 grafts in the future. Now he is 40 years old. I predict that in the next maybe 15 years he will need this graft.
Can you show us what the results look like? Or
yeah, I select this patient because the tempo peaks.
Yes,
yeah,
perfect.
But see, this is the result.
So yeah, a lot of people have said, does Dr. Zarev do temple peaks? Because I don't see him restore them. So here we have a perfect example.
Tempo peaks in very rarely cases when the patient, when the condition of the patient allows this, because the aggressive tempo peaks require aggressive hairline or hairline like in person who never lose his hair. And that's why if the condition allows, then I do it. In this case, I restore the tempo peak, especially in the right side, and because the problem was bigger, the left side was smaller, as you can see here. And this is the result of this patient. Of course, when I work on tempo peaks, I'm very careful with the type of the hair that I select, because the hair here in the tempo peaks usually is very thin and grow very slow. And if you don't select the right hair, doesn't matter that they are single, this will look unnatural. That's why I select hair from the close area, behind the ear, and something else. The hair in these parts change the colors usually first compared to the rest part of the donor area, in this case temporal or occipital area. And that's why if you don't select the right hair, which will change his color in the same time with the rest part of the hair, then this patient may have a problem in the future with dark hair in this area of implantation and white hair in the rest part, which will be very unnatural. And the result of this patient, this is the condition of this patient before, and but this patient used 1 year before the surgery because he decided, and he continued to use treatment after the surgery, of course, to try to save his natural hair as much as possible, of course. This is the condition, and this is the result. This is the hairline of the patient.
Wow.
You can see here. This is the sides, the tempo peaks here.
It's very, very good.
This is the
Incredible.
density. The hair is not very long. It's around 5 maybe centimeter, between 4 and 5 centimeter.
Yeah.
See the design of the hairline, the micro planning of the hairline here. The first hair in the hairline should be very thin and with slow growth compared to the rest part, because if they are not thin, doesn't matter that they are single, they will look unnatural. Usually the best place is wall part of the occipital area for the hairline. See this hair here.
Yeah. Wow.
And the temple peaks again.
Very, very
If you see this patient in person, you will not understand that he had a hair transplantation. On pictures from the temple peaks. This is a transplanted hair.
That's all transplanted. You
This
cannot.
this area here.
Yeah.
This area is transplanted, but you cannot see where is the border between the transplanted here and his natural here. And this is a donor area. I extract here from here, but you cannot see the holes or the scars.
You extracted hair from there, and you can't.
Yeah,
Wow.
from everywhere. I use the whole surface of the of course, not from this area. I
Yeah.
extract from all of this area different amount. But yes,
Mm.
this is donor area. See the direction, the angle, compared to the surface of the skin is very important parameters to look natural.
One other question is that does Dr. Zarev do repair cases? There's been a surge of repair cases, as you know, because there's a lot of low-cost hair mills that are doing bad work. Do you take these patients on? Last time I spoke to you, and I may have misspoke on the forum, and I said that I was under the impression that you don't usually, because a patient that already has a depleted donor area may not benefit from your technique because you're not able to give them the best possible outcome.
Yes, unfortunately, nowadays and in the future, many patients will need repair surgery. Okay. Yes, I do repair cases, but during the consultation, I explain the patient what is the limitation because of the previous surgery, and I try to achieve the best possible result. Sometimes we need just to add more density. In this case, it's easier if they have enough follicle units, of course. But sometimes when the hairline is done with, it's very bad planning, it's very low or not natural, then we need to extract grafts from the hairline to achieve better hairline. This is more difficult. But again, if the patient needs this type of surgery, I do if it's possible. I can show some example, but
Let's see an example. That's a good one.
see what patient came to me.
Mm,
See now, this
I
is
see.
done by very, how to say, popular clinic in Turkey, which have a very aggressive
Mm,
advertising in Bulgaria, very aggressive. And see
mm.
what's happened. I'm always angry when I see something like that.
Now,
Nothing right here. Everything is wrong. The type of graph is wrong. The direction is wrong. The distance between the
closure.
natural hair. Everything is wrong here. He looked like he wear a hat at all time after the surgery. He never take off the hat because he's ashamed of his outcome. See,
Wow, that's
it's
bad.
and the problem is that they make see the donor areas. See the
Mhm.
signs from the extraction. See here.
Mm.
And before the extraction, this donor area was very good. In the clinic, they make the surgery on this guy when he was 19 years old.
Oh my,
And
19?
he
Oh
was
my God.
19 when they done the surgery. And nobody calculate what will be the future losses for him. And as you can see now, these pictures is done when he's 21, 2 years later, 2 years after the surgery.
Oh,
And it's very visible. He'll reach node 6 maybe before 30. And in cases like this, of course, I take the case and do my best. But the problem is that they spent a lot of grafts
oh yeah.
for this surgery. They extracted more than 4,500, and on his head he had not more than 2,000 grafts.
Oh
And
my
they spent more
gosh.
than 2,500 grafts just spent. And of course, in this case, we need to extract these grafts because see the type of the hairline, the level and the shape. The first surgery, I extract these grafts from this area here and implant in the frontal area. And this they was more than 1,000 grafts in the frontal area. And then in the second surgery, I extract more of this area because I cut maybe 20% from the grafts under the skin, and they produce hair again. And then in the second surgery, I extract again maybe 90% from this that I was not able to extract in the first surgery. And now he have maybe 30 hair which continue to grow, and in the third surgery I will extract them. But in the second surgery, I extract from the donor areas and implant in the frontal parietal area to achieve a better coverage. This is the after the second surgery and before the third surgery, because see this hair here.
Yeah.
I need
That's
to
where it was
remove them,
moved.
and I need to increase a little bit the density, and he needs a little bit more thin grafts here. But unfortunately, I was not able to remove all the implanted grafts, and they are with wrong direction here inside, and they change a little bit the shape of the hair, but nothing to do. But this is the outcome after the third surgery, the next surgery. I will extract these grafts, and the skin. The good news in that skin in the forehead recover very good, and usually don't produce a scar. Even after this bed implantation, even after 2 extraction here, see how the skin look like.
Wow.
And this is because of the type of the skin. Usually, the skin in the forehead don't produce a bad scars. See, in this area, he had a lot of grafts before. I will compare the pictures.
Yeah, let's see the comparison. You know, I think you just explained exactly. I've had a lot of people who have come on the forum and have complained about their repairs because they're not able to achieve what they want in the one surgery. But what you've just explained now is the reason why you can't do a repair in one surgery. There's so many to remove the hair follicles from the hairline. Not only do you have to remove them, but there's some hairs in the telogen phase, which will then grow. So it's impossible.
And some of the hair, listen, because during the implantation, sometimes the deep of implantation is different compared to the native deep. Do you understand me? The level of the graft is deeper compared to the native level, and sometimes you cannot predict because this depends on the technique of the guy of the person that implant the grafts. And sometimes you can even cut the hair under the skin, and after 1 month this hair grow. You can cut between 5 or 20%, and this requires second surgery to extract this 10 or 20%. I never achieve full extraction in this type of hair with one surgery. I always, in my practice, of course, I always need second surgery to clean the skin from this bed implanted hair.
Yeah, and maybe even 3 surgeries, right? Because even after
in very
2,
rare cases, yeah, in this case just left maybe 30 hair which need to be extracted.
yeah.
But his condition is much better compared to the condition before. Now he don't wear hat.
Yeah. I love the fact that you were able to share your screen and share all these pictures. I think that this is really going to help people understand, because it's one thing to say it and it's another thing to say it and then see it in real time. Number one question that everyone's going to tell me is, how do I get in to see Zarev sooner? How do I get him? I have a consultation in 2024, but can I see him next year? Those are going to be all the questions that I'm going to get.
Yeah, I know, but again, in the future, I will plan to teach some other surgeon to start to perform the same type of extraction and implantation, the same surgery. And I hope that this will change the waiting list.
Thank you, Dr. Zarev, for your time. I think that your technique is something that people are very interested in. I'm very interested in. I know there's a lot of admiration for your work. I admire your work, and I can't wait to see more of it. Thank you for taking the time to explain your approach, your process, and clarify some things that may have been confusing or may have been misinformation spreading around online. So thank you so much. Just for anyone who wants to reach you, you're at Dr. Zarev on Instagram, right?
Yeah, I have a website. When you search about Dr. Zarev, you can easily find my website. And in the website, I have my contact numbers, email, and everything that they need to contact me.